You are watching the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Big topic today, new treatment options for people suffering with AFib. With us, we have a well-known, world-renowned cardiothoracic surgeon, Dr. Whitaker. Dr. Whitaker, welcome to the program.
Thank you, Randy. Nice to be here.
Now, you're over at Eisenhower.
Yes.
And I've wanted you on the show for quite some time, so I'm glad to have you here. So tell us about your role there.
Well, I'm one of the two cardiothoracic surgeons at Eisenhower. Myself and my partner, Dr. Wilson, are the two surgeons that do all of the heart surgery, the lung surgery, and a bit of the vascular surgery that's performed at Eisenhower.
So you also have a interventional AFib program.
Yes, we do.
Expand on that.
We became very interested in the treatment of AFib, or atrial fibrillation, a number of years ago. And what we realized along the way was that it wasn't purely a medical or a surgical treatment option for patients with AFib, that it also very clearly involved the electrophysiologists who are cardiologists.
Okay.
And there are two electrophysiologists at Eisenhower, two excellent ones, who do AFib ablations. And then there are two surgeons. And what we decided a number of years ago was that it would be optimal for patient treatment and for addressing the disease of AFib if we could collaborate and have a collegial approach to the treatment of it. And therefore, what we wanted to do was form an interventional AFib program,
okay,
one of probably a dozen in the United States, where there really was a collaboration between the medical doctors and the surgical doctors to completely treat the patient with AFib, address all of their needs, and really kind of evaluate what would be the best treatment option for them, whether it was going to be medical therapy, interventional therapy, or surgical therapy.
You know, Eisenhower is, as you know, and it seems that everybody knows now that they are known as the first people to do a lot of these new treatment options.
Yes.
And the topic we're talking about today, this new minimally invasive treatment for AFib, you're one of 5, is that true? 5 thoracic surgeons in the world that do this.
One of about 5, yes, give or take one.
Okay.
A lot of patients, Randy, don't feel well. They don't have any energy. They don't have any exercise tolerance. They feel tired and fatigued all the time.
Are there doctors that think that this is not that big of a deal?
Yes.
AFib? And they just throw medications at it?
Yes. Most physicians, interestingly, as educated as they are and as much as they care about their patients and as much as they want to do the right thing for their patients, most physicians, either through training or background or experience, believe that AFib is a nuisance rhythm. It's a nuisance.
What does that mean? Tell me about that.
Well, patients with AFib, they call the office a lot, and they say, I'm not feeling well
today.
Like
a pain patient, almost.
Almost like a pain patient or a patient with some other malady or affliction that...
So they're brushed off in a way?
They're brushed off in a way.
Interesting.
And...
because there's not much, or the thought is there's not much you could do about it? Is that why?
The thought is that you treat these patients with medicines.
Like blood thinners?
Blood thinners, like Coumadin, which has an enormous number of potential complications, and aspirin, and drugs that will slow the heart rate down or control the heart rate, and therefore, presumably, make the symptoms less.
So that's a big misconception. Not only with the lay people, but in the medical community.
Yes.
Okay.
Yes.
So, well, tell us then the different treatment options now, and what you're doing, because I guess what you're doing is dramatically different.
Yes.
Than
well, there are basically 3 ways to treat AFib. There's the medical way, and the medical way, as we've discussed, is to thin out the blood, so hopefully you don't form clots inside the heart that can then break away and cause strokes, and to slow the heart rate down. So those are the 2 basic tenets behind the medical therapy of AFib.
So AFib, though, is an electrical problem in a way? Is that
yes.
One way to put it?
Yes.
Okay. So they do this by giving blood thinners, but does that really take care of the...
All it does is ameliorate the symptoms,
okay,
and hopefully prevent some of the potential complications. It doesn't take away the AFib. AFib has been described as an electrical storm that goes across the atria. And
it's intermittent? This isn't something that happens all day long?
Well, there are two types of AFib. One type is intermittent, and that's called paroxysmal AFib, and that's where it comes and goes on its own, spontaneously. The other type is called continuous, and that's where you're constantly in the AFib.
Which one is more dangerous?
Well, I don't know if it can really be classified as which is more dangerous. They're both very disturbing.
But they're both treated the same way?
And they're both treated the same way.
Medication is the first
line. Yes.
Okay.
Now, in all fairness, medication for about a third of patients with AFib, whether intermittent or continuous, is effective, and it works. The second approach is where our colleagues, the electrophysiologists, who are cardiologists who have done special training in the electrical conduction system of the heart, can take you to the EP lab, and through a variety of catheters that they thread up into the groin and then subsequently into the heart, can ablate certain pathways that may be causing the AFib. Okay. And in certain patients, that is a very effective therapy, but in a majority of AFib patients, ultimately proves to be not as effective as what we can do surgically. Okay. And then the third form of therapy is what we're ultimately here to talk about today, and that's the surgical treatment of lone atrial fibrillation. Now, as a definition, lone atrial fibrillation, or lone AFib, is the presence of AFib in a patient, in a person, who does not have organic heart disease that we are going to operate on.
So their heart is fine.
Their heart is fine.
No blockages, just that electrical problem?
That's correct.
I'm following that right? Okay.
That's right. So they don't have coronary disease. They don't have valve disease, heart disease. They may have high blood pressure. They may have thyroid issues. They may have problems with sleep apnea. They may have other issues, but they have an electrical disturbance in their heart that is unrelated to any other issue in their heart, may be related to other issues going on with them. But ultimately, it results in AFib.
What age do people get this?
Well, you know, that's an interesting question. AFib really is a disease of the aging. It's related to aging. And, of course, as the demographics of our country change and the population ages, the baby boomers, it's safe to presume that more and more people will get AFib.
60, 70 years old?
The peak incidence is in the early 70s.
And it only gets worse?
And it only gets worse with time, that's correct.
Is that right? And most people just take medication. Okay, so the surgical options, I'm sorry for interrupting, Go ahead.
Well, the surgical options really are the best options that are available. Now, what's interesting, if one considers the evolution of the so-called maze procedure, it began about 35 to 40 years ago as an open technique that was very invasive in patients having other open heart surgery. The procedure itself was very effective. And it's that old saying, the procedure was a success, but the patient died kind of thing.
All right.
And it wasn't very well adopted. So it was abandoned in the 80s. In the 90s, surgeons began to reconsider the operation, and they realized that if they didn't do it the original way, but they used alternative technologies to create the lesions in the heart, the procedure would become much less invasive and much less dangerous, and maybe a little bit less effective, but the trade-off was worth it. Okay. And so we adopted alternative technology in 2002 when we began our open maze procedure at Eisenhower, and became one of the leaders utilizing this particular technology in the world.
But so I understand this correctly, open maze procedure, that means these were people that were already in for heart surgery.
Yes.
And that was the only time it was indicated.
Yes.
So the chest is open.
Yes.
So you might as well go in there and
do it.
And short circuit, in a way,
yep,
that electrical area, so the AFib stops. And so that was the open maze, and that was the only time you ever did it?
That was the only time we ever did it.
Open heart surgery patient?
Yes.
Okay.
And then a few years ago, a number of surgeons got together and really thought, you know, this has become an effective procedure.
Now, by the way, I should interrupt here for sure, because you say a group of physicians. You were in this group.
Yes.
You told me that you sat around and you had a meeting. You said, how can we do this better? Why do we have to wait for the open heart to even do this? Is that right? I paraphrased, of course.
So the goal was to design a procedure, really, that was minimally invasive, that would adequately address these patients who didn't need open heart surgery yet had AFib, that was acceptable in terms of an outcome and in terms of risk, and was something that we could offer patients with minimal risk and the best outcome available.